So today's topic is intestinal obstruction. So obstruction can happen anywhere, in esophagus, in stomach, in pylorus, in small bowel and intestine, and also other hollow tubes in the body like ureter. Ureter can also get obstructed, like common bile duct. It can also get obstructed. Today I am going to talk about intestinal obstruction generally, and there will be a huge overlap of small bowel and large bowel. But the specific causes which we deal in large bowel I will discuss in details, but the basic pathophysiology and mechanism will be common to both of the small bowel and the large bowel. So we will be discussing about the pathophysiology, how does the patient present, how would you investigate to confirm the diagnosis, how would you treat the patient, and what can be the complication which we should be aware of and we will deal. So small bowel and large bowel are the two main. When we talk about intestinal obstruction, we are dealing with small bowel and large bowel. I have written esophagus, pyloric canal and other tubular structures just to make you clear, because esophagus, if it get obstructed, the condition is called as dysphagia. Patient is unable to eat. If stomach or pyloric canal can get obstructed by anything, the condition would be called as gastric outlet obstruction. Patient will have projectile vomiting and he is unable to eat and the stomach will get distended. So wherever the obstruction is in the body, there will be two natural mechanism which will come in play initially. So the first mechanism the nature initiates or starts or kicks on is the vigorous peristalsis. Naturally, the peristalsis is trying to overcome the obstruction. So this is the stage 1. At this point of time, the initial presentation, the clinical presentation will be different. In second stage, when this mechanism fails, the second mechanism comes on. There will be total loss of peristalsis. The proximal part of obstruction to the obstruction would dilate. The distal part to the obstruction, contents, they will disappear, they will move forward and that part will collapse. So you will have a dilated segment and you will have a collapsed segment, and in between will be the obstructive segment. So what can cause the obstruction? This is a detailed slide. There are two basic type of obstruction. First is the dynamic or mechanical obstruction. This is that obstruction which has some mechanical causes. There is a physical cause which is causing the obstruction, and these are called dynamic obstruction. The second part is without any mechanical part. These are called functional obstructions, and these are called as adynamic obstruction. The most of the clinical presentation, most of the patient what we see are having mechanical obstructions. Mechanical obstructions can be divided into three categories. So whenever there is a mechanical cause in that tubular structures, the cause can be inside the lumen, that they are called as the intraluminal. Some physical structure is present inside the lumen which is causing the obstruction, and these are the common causes of intraluminal obstruction. The commonest one in large bowel are the neoplasms. The malignancy can physically obstruct inside the lumen of the large bowel as well as any other part of the bowel. Then comes the bolus obstruction, some sort of a big bolus. It can be food bolus, it can be phytobezoars, some worms, trichobezoars, even gallstones. So these are bolus obstruction can happen mostly in small bowel, not in large bowel. Why? Because small bowel has a smaller lumen as compared to large bowel, and there is an junction between the small bowel and the large bowel. There is a big ileocecal valve, so which stops all the boluses going forward into the large bowel. So that is why the bolus obstruction are mostly known for small bowel. Then comes another important cause, the mural causes in the wall of the intestine. They can be the strictures. Strictures mean the fibrotic narrowing of the wall of the intestine. They can be benign and they can be malignant. So most common benign stricture of GIT, you should always remember in our setup, in our country, the cause number 1 is tuberculosis. Crohn's disease is an inflammatory bowel disease. So tuberculosis can happen anywhere in the GIT, but most common in that part of the intestine where the Peyer's patches are the most, terminal ileum and the rest of the small bowel. Because the mycobacterium, they rest and they stay and they reside in the Peyer's patches. And then the malignant strictures. So tumor can protrude into the lumen, and tumor can actually involve the wall of the intestine, and they can produce strictures. If you remember, there are three types of malignancy: the tubular variety, the annular variety, and the strictured variety. Then comes the volvulus. So when the intestine twists upon its own axis, this is volvulus. It can happen in the stomach, it can happen any part of the small bowel, cecum, sigmoid colon. Those parts of the intestine which are free to move around. It can rotate, it can twist on its axis. So this will cause the obstruction. And in large bowel, the most common volvulus is the sigmoid volvulus. Then the intussusception, when one part of the intestine moves into the distal part of the intestine. So it's sort of like a telescope. One part moves into the other part. This is the intussusception. And this usually happens when there is a small lead point, when there is a small mechanical point which can lead the peristalsis and converts into a intussusception. And then the diverticulitis. Before it was a disease of West countries, but nowadays because we are eating what they are eating, so we are also getting diverticular disease. So in diverticular disease, when there is repeated inflammation, the bowel wall get inflamed, they get strictured. So that is why in diverticulitis, patient can have sort of obstructed features. Then come the causes which are not involving the lumen or wall of the intestine. They are present outside the wall of the intestine. They are called the extraluminal causes. And most common cause is the adhesions. Adhesions means when the two parts of the intestine, they unite. The serosa to serosa, they meet. And this is most common in postoperative scenario or any sort of inflammatory scenario. And the most common inflammatory condition in which adhesions can produce later on peritonitis due to any cause is a severe inflammatory condition of peritoneum, and later on the gut is prone to develop adhesions. And when you operate on a virgin abdomen due to some other cause, and when you handle the intestines, they get inflamed. There is inflammatory response, and later on they produce adhesions. So adhesion is a very common cause, and mostly adhesions, the small bowel is more susceptible to the adhesions rather than large bowel. Then comes the commonest thing, the hernias, inguinal hernias, umbilical hernias. When the intestine protrude into these orifices, they can get obstructed. So functional obstruction, adynamic obstruction, is a very confusing obstruction because clinically it's very difficult to differentiate, is there a mechanical reason behind or it is just a functional one. The commonest adynamic functional obstruction is paralytic ileus. Most common cause of paralytic ileus, as I told you, when the surgeons intervene. So after every operation, patient have done in general anesthesia, or because the intestine have gone due to drugs, due to surgeons handling, they have gone into ileus. This is a adynamic without any cause. It is just a functional obstruction. And if you care the patient, give fluids, care about the electrolytes, this neurogenic shutdown will recover in 24 hours or 48 hours. Postoperative causes can happen and electrolyte disturbances, which is the commonest electrolyte which can lead to paralytic ileus. Sodium and potassium, but mainly potassium. If there is hypokalemia, then there is a term which is called pseudo-obstruction. This is also a adynamic obstruction. As the name shows, it is a pseudo-obstruction. There is no cause. If there are some retroperitoneal surgeries, then medical cause is uremia and spinal injuries. So overall, if you see the intestinal obstruction, the most common cause are the adhesion, what we see, and then the carcinomas, 15%. So malignancy are mostly related to the large bowel, but small bowel can also have malignancy. The other causes are not very common. Inflammatory causes and hernias are the I think third most common causes. And simple pseudo-obstruction and simple fecal impaction in old age, they can also lead to intestinal obstruction. Large bowel obstruction. The commonest cause are the malignancies. If you see a patient with large bowel obstruction, the number one cause you should rule out are the tumors. Then the volvulus. Then comes the pseudo obstruction. Simple fecal impactions constipation, severe constipations. The stools, they harden so much in the rectum and sigmoid colon that patient is unable to evacuate at all, naturally in very old people, and they can cause obstruction. Then comes the different foreign bodies, diverticulitis, and some anorectal congenital malformations and the megacolon. And small bowel obstructions, number one, topmost are the adhesions due to any cause. The second cause of small bowel obstruction are the hernias. Hernias, inguinal hernias and the ventral hernias. Ventral hernias concludes umbilical hernia, paraumbilical hernia, epigastric hernia. So small bowel is notorious to enter into these hernias and they can get obstructed. So three common causes: adhesions, any hernia, and strictures in small bowel in our setup are mostly benign. They are mostly inflammatory. And the most common inflammatory stricture is tuberculosis. So these are the three common causes. So you see the neoplasm on the small bowel is way down, and in the large bowel is the number one. Special types of intestinal obstruction, just few names: internal hernias, diaphragmatic hernia, the retroperitoneal fossae, the mesenteric defects. Strictures again the same: bolus obstruction, gallstones, gallstone ileus. Actually the gallstone has come from the gallbladder, so it has to be a big gallstone which can obstruct. It has to erode the gallbladder wall, it has to erode the duodenum, and then the gallbladder stone will enter the duodenum and pass all the way down to the terminal ileum. So how do we know that there is gallstone ileus? There is a triad. Patient will have small bowel obstruction, number one. Number two, patient, because there is a fistula between the duodenum and the gallbladder, some air will go into the biliary tree. So patient will have pneumobilia. Air in the biliary tree is called as pneumobilia. And third, if you get an X-ray done, you will see some opacification in the right iliac fossa, that stone shadow. So these are the three cardinal signs, and it is called as regular triad. Then food, unchewed food, you can pass it on and it can obstruct anywhere. Then trichobezoars. Tricho means hair. People who bite their hair. Hair are undigested material. They are undigested proteins, so they pass it on. And phyto means food. So if you pass on unchewed food, it will be called as food bolus. If you pass on undigested food, that is called phytobezoars. Worms, Ascaris lumbricoides, they are big worms. They can actually cause bolus obstruction in the small bowel. And then come again adhesions and bands, volvulus, sigmoid, cecal, and compound volvulus. Compound means multiple organs, they can get twisted to each other. So what happens when there is obstruction? Peristalsis has a key role in producing this pathophysiology. Remember the two stages I told you: initial hyper exaggerated peristalsis, and later on absent peristalsis or less peristalsis. Then comes what are the intraluminal factors, what sort of bacteria the intestine has. Small bowel has different contents and large bowel has different contents. Large bowel will have more gas and the small bowel will more liquidy contents. So this toffee-like structure, let us assume it is the intestine, and this orange part is the obstructing lesion, whatever. In this, there will be food contents in which stasis will start and bacteria will flourish. And when the bacteria will flourish, they will produce gas. And some of the gas will come from the mouth also. Patient is also, when we are inhaling, we are indigesting some air also. So the important point in this, the higher the obstruction, more of the indigested gas will contribute. And if we move into the large bowel, the indigested gas will not have much role, but the bacterial gas will have more role. So this gas result in the distension of the bowel bone. And when the bowel distension will happen, the blood supply will start compromise. And when the blood supply will compromise, there will be hypoxia to the intestinal cells. And this hypoxia of the intestinal cell will contribute to less peristalsis. And this less peristalsis will contribute to more distension. So this cycle will start going on. On the other side, this hypoxia and the dead bacteria will contribute to further cell death. The toxins from the dead bacteria, they will translocate from the intestine outside and they will contribute to more cell death and resulting in sepsis, toxemia. So patient can go into septic shock. If you see this side, when there is venous compression, the gut will produce some fluids and there will be loss of water and electrolytes. Also, due to these distensions, patient will have more and more vomiting, and this vomiting will also result of water and electrolyte loss and resulting in what? Hypovolemic shock. So intestinal obstruction, patient will have two sorts of shock, the hypovolemic shock as well as the septic shock. So our goal of treatment in intestinal obstruction is correct and prevent the hypotensive shock by correction of fluid or electrolytes and prevent the patient going into the toxic shock. So this is again initial vigorous peristalsis to overcome the obstruction, stage 1. Stage 2, gradual paralysis and distension. Then stagnation of the contents with gas production, especially hydrogen sulfide will be produced, and increase the pressures resulting in hypoxic damage and septicemia, and fluid and electrolyte imbalance causing hypotension, hypokalemia, hyponatremia and hypovolemia. These three things will happen. So we have to replace all these three: sodium, potassium and water. We have to identify the cause when we see the patient, whether it is a mechanical cause or a dynamic cause, whether the obstruction is complete or partial, because treatment will vary. If it is a complete obstruction, the chances of going into septic shock will be more. If it is a partial obstruction, we'll give some nature a chance, the stage 1 a chance that maybe it will resolve by itself, and we will sort of optimize and resuscitate the patient. But if the partial obstruction is not relieving and it is going into the complete obstruction, the surgeon will come in play. And if it is a simple obstruction or strangulated obstruction. So now the clinical features. There are 4 cardinal signs of the intestinal obstruction: pain, vomiting, obstipation and distension. Obstipation is the absolute constipation, when the patient is not passing flatus or as well as stools, and constipation is when patient is passing sometimes flatus but not the stools, which is also sometimes called as relative constipation. So absolute constipation or relative constipation. So these are the 4 features which has to be present in a case of intestinal obstruction. Depending upon the level, the symptom will vary. The higher the obstruction, the patient will have more vomiting. If let us suppose the obstruction is at the level of pyloric canal, which is called as gastric outlet obstruction, so patient will have projectile vomitus containing stomach contents only. It will not have any bile. So the color of vomitus will also tell you what is the level of obstruction. And if the obstruction is at the mid-jejunal or ileal level, so whole of the proximal contents will come out. So they will be sort of yellow in color, feculent in color, and patient will have more vomiting. As you move lower down towards the large intestine, the vomiting will decrease, but the abdominal distension will increase because the large gut has more capacity to distend as compared to the small bowel. It doesn't mean the small bowel cannot distend, it can also distend to a very large amount, but not more than large bowel. So if the distension is in the epigastrium or in the umbilical region, so we think that most probably small bowel is distending. If the distension is in the lower abdomen or in the lateral flanks, the more likely it's a large gut distension. So that is how you identify the level of the obstruction. So pain will be always sudden and colicky in nature, because it's a hollow tube. The pain will be colicky in nature. It will be sudden and sometimes very severe. So character of the pain is also very important to elicit. The more gut will get distended, the patient will have more pain. And as I told you before, initial part of the obstruction, the gut tries to overcome the obstruction by vigorous peristalsis. So when there is vigorous peristalsis, there will be more severe colicky pain. And in the second part, when the gut fails to resolve the obstruction, the gut goes into ileus, the pain will settle down. Increasing amount of pain will be in the initial part of the obstruction, but later on the pain will settle down. But when the gut is in ileus, it will start distending, and the distension itself can cause the pain, but that character of the pain will be different as compared to the previous. Initially it will be colicky, later it will be continuous and dull. But let us suppose if that part of the intestine gets some ischemia, again it will become more severe. It will be associated with fever. It will be associated with signs of toxemia, and it will be continuous dull pain present all the time, and patient will look sick. Constipation or obstipation will be more linked to the large gut obstruction. So in the large bowel, distension is very early, pain is less severe, and vomiting and dehydration are the late features. But altered bowel habits, bleeding per rectum, if that is the cause, they will present early. In addition to these 4 features, the other features, like if the patient is getting strangulation, if it is getting ischemia, fever will set in. If patient is losing water because of vomiting, dehydration will set up. So all these features will come in. Patient will develop tachycardia. Patient will get fever. So what are the features which sort of govern clinical symptoms? Number 1 is the location of the obstruction. Number 2 is the severity of the obstruction. Number 3 is what is the underlying pathology. So these are the factors which will sort of give the different variable pictures in the different part of the intestines. On examination, what will happen? Abdomen will be distended. If it is more central, most likely the small bowel obstruction. If it is periphery located, it's large bowel. If it is massively distended, most likely it is large bowel. And if you tap that abdomen, which is very thin walled, you can elicit the peristalsis. Bowel sounds. Initial part, the bowel sounds will be hyper-resonant. They will be exaggerated. But later on, when the ileus set in, the bowel sounds will disappear. If the patient is developing ischemia or strangulation, the features of peritonitis will set in. And there will be tenderness, localized guarding, rigidity, and if there is perforation, the patient gets full-blown peritonitis. If there are any associated masses or tumors, you may be able to feel in the right iliac fossa or in the mid-epigastrium or in the umbilical region, you may be able to feel. Never forget examination of inguinal and femoral hernias whenever you're doing abdominal examination, especially if you are examining the intestinal obstruction. And if you have not exposed the inguinal orifices, you will miss the inguinal hernia. Then comes the digital rectal examination, the hallmark of the surgeon, very important examination. So what will be the finding when you do a digital rectal examination in intestinal obstruction? The contents, whether the fecal matter is solid, it is soft, or it is empty. So these are the 3 features which can tell you. If it is empty, it means it is obstructed upper side and there is nothing coming down. If it is soft, it means it is simple constipation or partial obstruction. And if it is hard stools, it means the stools are impacted. And if it is blood stained, so it means it is bleeding from somewhere, there might be some growth. Then you will investigate the patient. So patient who are dehydrated, who are losing potassium in vomitus, they will have hypokalemia. If you send the sample for sodium and potassium, both can come low. Patient may have hypokalemia, patient may have hyponatremia. Then you will do the CBC. Why you want to do the CBC? You want to check hemoglobin. You want to check the white blood cell counts. If patient is having leukocytosis, it means patient might going into ischemia or strangulation. You will see the creatinine, urine specific gravity. This will show you the amount of dehydration, amount of shock, because if these things are rising, it means patient is in shock. If hemoglobin is low, it also tells you that patient is bleeding somewhere. So in lactate levels, you can check to see if patient is in sepsis. You don't check lactate level for every patient, but you only check lactate levels in which clinically you are thinking patient is going into sepsis. If you get arterial blood gases, you will get metabolic acidosis with or without compensation. So imaging, simple x-rays, contrast x-rays, the CT scans. So all these things can help you diagnose whether there is obstruction, what sort of obstruction, complicated or uncompleted. Best, simplest investigation is a simple plain x-ray of the abdomen. And when you ask for simple plain x-ray abdomen, it has to include the diaphragms up to the pelvis. If the patient can stand, you can do in an erect posture. And if patient cannot stand, you can do it in a supine position. But simple X-ray can tell you lot of things. Initially, it was thought only the erect posture X-ray is better. But nowadays, you won't get much information because erect posture where patient has to stand, patient may not be fit enough. The spine X-ray is good enough. The only edge the erect posture X-ray is over the spine X-ray is if you have a perforated viscus and patient have peritonitis, then you may be able to see free gas under the diaphragm. But if only for intestinal obstruction, you don't need a erect posture X-ray. Spine X-ray is enough. Jejunum, ileum and large bowel. These three structures we have to identify when we see an X-ray. Jejunum and the large gut have mucosal folds, and both these folds are different from each other. So if you see the jejunum, I'm sure you have heard this valvulae convenientis. These I'll show you in the X-ray also. These are the mucosal folds which are very clearly visible when you see a normal X-ray. In large bowel, these are the haustration, the haustral folds. And what about the ileum? Ileum is characterless. It does not show any features of any folds. We'll just see. Cecum will be in the right iliac fossa. Sigmoid colon will be in the left iliac fossa. The transverse colon will be going across the abdomen, and on both sides there will be left and right colon. Can anyone tell me what will be the features, characteristic features in a case of intestinal obstruction before I show you the X-ray? The proximal portion will have fluid, the proximal portion will have gas, and now there is stasis. What will happen? The gas and the fluid will separate, and there will be a sort of air fluid level. So this is the thing you are looking for in the small bowel obstruction. In large bowel there is more gas as compared to fluid. So if there is a massive distension of the large bowel, that will be seen in the X-rays. This is an X-ray abdomen, erect posture. Why it is erect posture? Because you can see the air fluid level. Air is always black, fluid is always white. So there are multiple air fluid level. Plain X-ray abdomen, erect posture, showing part of the diaphragms and the pelvis, and I can see multiple distended loops with multiple air fluid levels. Now you compare this X-ray with the last X-ray. This also contains the dilated loop, but it does not show you the air fluid level. So probably this is done in supine position. And you can also appreciate small lines going across these are the valvulae convenientis. So these are the dilated loops of the jejunum because it is showing the mucosal folds. And these are the loops of ileum. They are characterless loop. They are just hollow pipes. So these are everything proximal to the obstructed point will dilate. So obstruction distal will not be visible on X-ray because the gas is absorbed. So it will not be visible. So in first X-ray we can safely say there is an obstruction in the terminal ileum. If you see a little bit carefully, you are unable to see gas in the flanks because there is no gas in the right colon or in the left colon. So we can safely say that probably this is obstruction at the level of terminal ileum because I can see whole of the ileum and part of the jejunum. In this I cannot see any ileum. I cannot see any characterless loop. So probably this is obstruction at the level of jejunum. So that is how you read an X-ray. And in the middle one, I can see multiple dilated loops present in the center abdomen occupying the upper part of the abdomen. It seems the whole of the loops are pushed upwards. And I cannot appreciate any mucosal folds. It looks like they are characterless. I cannot see any air fluid level. Probably it is done in supine position. So on seeing this X-ray, I cannot appreciate any other gas in the pelvis. I cannot appreciate any gas in the right iliac fossa or in the left iliac fossa. So I think this is a case of intestinal obstruction in the ileum and something in the pelvis which is pushing everything upwards. Maybe fluid, maybe some growth, we don't know. For that we need some other investigation. In a normal person we can get 1 or 2 fluid level, so that is not abnormal. So X-ray should always be correlated with the history. What about these X-rays? All X-ray abdomen plain, a large snake-like distended bowel loop with some lines. These are the haustration folds. So if this is the small bowel, the vulvi convenientis will be like this, going across one wall to the other wall, right? Like some piles or stacks of something stacked over each other. These are the vulvi convenientis. And haustration fold will start from one fold and stop in midway. Then it will be not equally spaced. So this is the main difference. You can appreciate also. So it starts from one wall but not reaching the opposite wall, and they are irregularly spaced. So this is the main difference between the small bowel and the large bowel. So this is a large loop of intestine going transversely across the abdomen. This is the dilated transverse colon. This is the dilated cecum, and this is the dilated descending colon. And there is a abrupt cut off here. So there is obstruction here. So that is why the whole of the proximal gut is distended. But you are unable to see except this small loop. The small bowel is not dilated. So why it is not dilated? If there is obstruction here, the gas should go all the way behind, but small bowel is not visualized. Why is that? Because there is ileocecal valve and is a competent valve. So it is not allowing the gas to go back. So this patient may not have some vomiting. He will have more distension. So if there is obstruction at this point due to malignancy, and the other obstruction is because of ileocecal valve. So there is obstruction at 2 points. So what sort of danger in this bowel is? It can massively distend. It can perforate because there is obstruction at 2 points. So this is another X-ray showing cut-off point and massively distended large bowel. This is another massively distended 7 centimeters. These are the X-rays of large bowel. Then this is a special type of obstruction which is called as closed loop obstruction. You can see this diagram showing ascending colon in the cecum. The ileocecal valve is competent and there is a lesion in the proximal part of the transverse colon. So this potentially is obstructed from 2 points. In many of the patients, ileocecal valve is also can be incompetent also. So when this is a competent valve, what is the function of ileocecal valve in normal persons? It prevents the large gut flora, bacteria to regurgitate backwards. So it's a one-way mechanism. So it will allow the small gut contents enter into the large bowel, but because in the large bowel the flora changes and there's a lot of production of gases and absorption of water, and ultimately solid fecal matter is left over. So this has more potential of toxic flora. So that is why ileocecal valve is there, and sometimes it is incompetent also. So if it is competent and it is working and there is another obstructed lesion, so the gut will obstruct in between these 2 points, and this is called as closed loop obstruction. There are many types of closed loop obstruction. So this is one of the example when there is a lesion and proximal. This lesion can be in the sigmoid colon also, and the proximal whole portion will be distended. This other diagram is also showing a closed loop obstruction. There is a small hernial defect and the gut has protruded inside, and now this has closed at 2 points. So this will also become a closed loop obstruction. There is another closed loop obstruction, that is sigmoid volvulus. It is also constricted at 2 points. So what are the main causes of strangulation, which is the most fearsome complication in any intestinal obstruction? Hernial orifices. So hernias, as I told you, this is a very common cause of obstruction. And why we operate hernia even if it is asymptomatic? Because we are afraid that it might get obstructed and later on can get strangulation. Then the volvulus, intussusception and closed loop obstruction. Ogilvie Syndrome. This is another common cause of large bowel obstruction. It is also a pseudo obstruction. It is basically a functional obstruction. There is no mechanical cause. Basically what happens is the gut fails to propel or push the fecal matter forwards because of the absent parasympathetic or increased sympathetic output. Gut fails to push the fecal matter outside and resulting in hardening of that fecal matter and proximal distension. So there are a host of causes which can attribute or contribute to this obstruction, but there is no mechanical cause as such. All the features of this obstruction will be the same as of any large bowel obstruction, any mechanical bowel obstruction. So problem with this obstruction is very difficult to diagnose preoperatively. The only way you can diagnose is by excluding the mechanical causes. Other things like patient is very sick, he is in ICU, he is very old age, he has some stress, some operative response or some infective elements and other morbid conditions that can only give you clue. He might have this pseudo obstruction, but you have to rule out each and every cause of the mechanical obstruction, because very obviously if the patient has mechanical obstruction, there are more chances of getting ischemia and strangulation. But the other side is, if you open the patient with pseudo obstruction, you can't do anything. And because the functional obstruction is mostly in the distal part of the large gut, sigmoid colon, rectum, so whole of the proximal gut will be distended, and distended up to the point that the cecum is massively distended. So if you get a plain X-ray of a case of a pseudo obstruction, you will see massively distended large gut up to the cecum, if the ileocecal valve is competent, and there might be an abrupt cutoff point in the pelvis or rectum. So the only fear is about the complications leading to perforation. We will see how we will manage this when we talk about the treatment. Volvulus. So when part of the intestine twists on its own axis, that is volvulus. It can happen any part of the intestine, or most common is the sigmoid colon, because it is very long, S shape. So when it twists around its own axis, that is called as organoaxial rotation, and it always rotate in an anti-clockwise fashion. Why does it rotate? Many causes. If the fecal load is very large, the sigmoid colon becomes heavy, so it can rotate. In certain patients, congenitally, the sigmoid mesentery is very long, so it can rotate. Certain diseases, chronic constipation, because the fecal matter gets loaded up in the sigmoid colon. Patients who are used to have Western diet, they can get constipated, and that constipation can lead to twists. Sometimes some adhesions or bands can add to the twist of the sigmoid volvulus. So whenever there is a volvulus, there are two stages. Stage 1 is twist of 180 degree. When 180 degree rotates, there is obstruction. The clinical features of obstruction will come, which are pain, distension, obstipation, and sometimes vomiting. But if the twist increases more than 180 degree, it becomes 360 degree, then there will be signs of ischemia. The veins will get compressed in this narrow part of the apex of the mesentery, and there will be ischemic changes, and the part of the bowel will get strangulated and maybe gangrenous. So when patient will have ischemic changes, the clinical features will change. As I told you before, patient will have signs of peritonitis, and if it is perforated, the patient will have frank peritonitis. So that is a danger in any volvulus. There is another term associated with volvulus which is called compound volvulus. When the two organs, multiple organs, they twist around each other. So this is a compound volvulus. So naturally damage will be more. So if you get an X-ray of sigmoid volvulus, what you will see? A twist, coffee bean sign, omega sign. It looks like a bent pipe. Some people say there are 3 lines, 1, 2 and 3. All 3 lines are converging into a point in the pelvis. So there are various signs associated with this sigmoid volvulus loop. Coffee bean is the most commonly used, and sometimes omega. So this is the diagnostic sort of a sign when we simply get a X-ray abdomen. So when you open the abdomen, you will see this large hose-like pipe, which is actually the sigmoid colon, which is twisted somewhere below. And if you open it late, it will be all gangrenous. So this is the complication. This patient would obviously be in septic shock. So how would you treat this patient? If you diagnose it at earlier point, when there is partial twist, it's not complete twist, it is 180 degree. You might be able to save the sigmoid colon. But if you diagnose it late, the sigmoid colon is already gangrenous and ischemic, as in rest of the intestinal obstruction, there are three options for any intestinal obstruction. Number one, conservative approach. Number two, surgical approach. And the third option will be optimization of the patient throughout. Because this patient will be in hypovolemic shock, this patient can be in septic shock, so you have to resuscitate the patient and try to judge whether you want to give a conservative treatment or a surgical treatment. Conservative treatment means there is a twist, it's a partial twist, the patient condition is stable, he is just showing signs of early obstruction. You do a digital rectal examination, you find that the rectum is empty, the walls are collapsed because there is nothing in distal part of the rectum. You palpate the abdomen, you find a large distended loop of bowel starting from the pelvis going right up from the left iliac fossa towards the central abdomen. You get an X-ray and it shows you sigmoid colon, this omega sign or coffee bean sign. Then you pass a flatus tube. You take a small plastic tube which is freely available and you sort of lubricate it well and pass and negotiate blindly through that twisted area. If you are successful, that part of the gut will be deflated. All the gases and the fecal matter will come out and the emergency is resolved. But it is a blind procedure. Sometimes it does not work. So then you use a scope. You pass a scope, whether rigid or flexible, find that twisted area from inside and negotiate a tube and suck out all the contents. This is called the endoscopic deflation of the sigmoid colon. So this is only a temporary measure. Of course, the chances of recurrence will be much more. And this can only happen if the twist is partial in early stages. When the twist is complete, 360, it will be of no use because already there are chances of venous compression and ischemia. In that case, you have to operate. When you open the patient, you see that picture which I showed you before. Now what you are going to do? There are two situations. One, the sigmoid colon is viable. The other, the sigmoid colon is gone. So this is very clear. You just take out all the dead portion and you are left with two parts of the intestine. A proximal part and the distal part. So what can you do with these two things? You can unite with each other or you can externalize like a double barrel colostomy. But our basic principles tell us that in emergency situation, we should not primarily anastomose. So best bet would be resect the gangrenous portion and take out both the ends as double barrel colostomy. The other name for double barrel colostomy is Paul Mikulicz procedure. Why it is called double barrel? Because it looks like double barrel of the gun. So that is why this is an emergency situation procedure. But sometime it can happen when you resect the gut. The distal portion which is going into the pelvis, it will not be very much long left and you cannot bring it out from the skin. It will be short. So if the distal end you cannot bring out through the skin, it is short because of your resection or involvement, you bring out only the proximal part and you close the distal part and leave it inside the abdomen. So what this procedure is called as? Hartmann's procedure. The other situation, when the gut is viable. Now what you will do? Gut is viable, distended like a pipe, and you can resect this also. Resect this also. Because if you leave inside by deflation, after deflation, the chances of recurrence will be more than 50%. You can do a Hartmann's or Paul Mikulicz. If the patient is not very fit, he is elderly. So what we will do is, we sort of put a tube rectally while we are palpating the abdomen. We negotiate the tube through the twist, which we would have untwisted manually and deflated all of the gut, and then we will do sigmoidopexy. We will fix the sigmoid colon with the abdominal wall so that it does not rotate again. Mesosigmoidopexy means we fix the mesentery also. And what about in elective surgery? If the patient has come to emergency, you have passed a flatus tube, you have endoscopically deflated the intestine, patient emergency is over, the distension is gone, patient is stabilized, you prepare the gut, you clean the gut, and you take the patient to elective scenario and you resect, do a sigmoidectomy, and then you primarily anastomose. You don't need any colostomy. So in emergency situation, the lesson is we do not like to primarily anastomose the intestine. Why? Because the intestines are contaminated. They are full of fecal load. So it is not very wise to anastomose in an emergency situation. So that is why the need for stomas come. So how would you manage acute intestinal obstruction? There are three phases. One is sportive treatment, the other is conservative treatment, and the third is the surgical treatment. So the first option is to put an NGT tube in the stomach, because we want to decompress the stomach. We want to decrease the load of the intestinal contents proximal to the obstruction. This load can be feculent also. Patient might be vomiting a feculent material. So we want to decrease the load of the intestines by decompressing the stomach. Also, if we want to operate on that intestinal obstruction, this nasogastric decompression will help during anesthesia also. The chances of, if the stomach is full, there will be chance of aspiration. So that is why we always place nasogastric tube whenever we are preparing in emergency a patient or in intestinal obstruction. Obviously, fluid and electrolyte correction is the most important, sodium and potassium, because patient would be vomiting all the way. There will be loss of sodium and potassium. So we have to correct by giving which fluid? Normal saline or Hartmann's. In emergency situation, when you don't know anything what you want to give Hartmann's. Of course, antibiotics, broad spectrum antibiotics, because we want to decrease the toxic load of bacteria which are proliferating because of stasis. They are releasing toxins. So we want to give antibiotics. Use of water soluble contrast in case of acute intestinal obstruction. One thing you should remember, barium should not use when the patient is in acute intestinal obstruction, because the barium has the capacity to solidify and it can further potentiate or aggravate the obstruction. So never use barium when the patient is having acute intestinal obstruction. Then what are the water soluble contrasts? These are special contrasts which are soluble in water, and the commonest example which is available in our setup is gastrographin. So what we do is, when we are in doubt, the patient does not have any mechanical obstruction, patient might have pseudo obstruction, patient might have early obstruction because of adhesions, so we give water soluble contrast orally. Large bowel, by the causes, we know that most causes are mechanical obstructions. So water soluble contrast is mostly given for small bowel obstructions, not in the large bowel. So these water soluble contrast, gastrographin will do two things. Number one, it is water soluble. It sort of absorbs the water and it sort of pushes if it is partial obstruction, so it sort of pushes its way out. So if we give water soluble contrast in the morning and normal patient, this contrast should be excreted from the stomach in 2 hours, and it should reach in the colon in about 6 hours. This is a normal pathway. So if the contrast has reached the colon in less than 12 hours, it means there is no functional there is no mechanical obstruction. But if it does not, then there is some mechanical obstruction. So water soluble contrast, some people uses it. Then observation and non-operative strategy in the partial obstruction. Surgical treatment, if the patient is developing signs of ischemia or strangulation, then definitely will go for exploratory laparotomy and deal the cause as such. So coming back to large bowel obstruction. So at the end, if you diagnose that this patient is a simple constipation, after all of your history examination, you just give transrectal enemas and the constipation will be. Sometimes the fecal matter become very hard and sometimes enemas don't work. So what we do is we sort of digitally evacuate the fecal matter, especially in very elderly or very sick patients. So we digitally evacuate and give enemas. If the causes are malignant And if patient is that we cannot operate, then some palliative approaches. We can defunction proximally, we can pass a stent. Acute pseudo-obstruction, if there is no perforation, we can wait because we know there is no mechanical obstruction. Some people, they prefer to give water-soluble contrast by enema. So that might help you. But if there are chances or signs of development of ischemia within 24 hours, then we operate early. Colonoscopic decompression if there is no resolution. And surgical management of all the causes. So palliative procedures of large bowel obstructions are stents or endoscopic dilatations. If patient has come to the emergency with obstruction, you can pass it before the surgery, relieve the obstruction, optimize the patient, deal it properly in elective surgery. If there is a right-sided obstruction, we will do a ileostomy, diversion. It's not a definite procedure, it's a temporary procedure. If it is a left colonic obstruction, we can do some sort of a colostomy proximally or a ileostomy. If it is rectal obstruction, we can do a sigmoid colostomy or sometime we can do a ileostomy also. Resection with or without diversion. So if you are able to deal with the tumor, you can resect the tumors. Try to remember these stages of surgery. Try to remember this. This can make you concept more clear. We go from below upwards. We go from below upwards. 3-stage surgery. A patient comes to you in emergency. He is very sick. He is obstructed. Your diagnosis tells us that there is a large gut tumor. He is very sick. We are unable to operate. What we do? We temporarily divert. So surgery number 1. We temporarily divert. We take the patient to ward. We optimize the patient, we diagnose the condition, we investigate the condition, we come up with the answer that he needs a proper tumor resection. We take the patient to elective surgery. Surgery number 2, we deal with the tumor. But the surgery number 1, which was just a defunction, remains there. We do not close it. So now the patient has 2 surgeries. There is no tumor, patient is followed up and there is no tumor recurrence. The patient still has the initial diversion still is there. So when the patient is labeled tumor free, then we go back for the 3rd time and we reverse the original surgery. So the patient had 3 surgeries. So this is sort of a 3-stage surgery. 2-stage, mostly in elective situation or sometime in emergency situation also. So in 2-stage surgery, the 2nd stage you go in and reverse that thing. That would be a 2-stage surgery. So 2-stage surgery can be done in elective surgery and 2-stage surgery can be done in certain procedures in emergency situation. And the single-stage surgery usually for elective surgery, you go in, do your job and that's it. The patient does not require any other surgery. To summarize, the intestinal obstruction, especially the large bowel, emergency situation, it can be a potential lethal situation. We have to diagnose it early and treat it early. Causes, we should all be remembering the causes. And the choice depends upon the etiology and patient condition. This line, the sun should not both rise and set. So in a patient who has unrelieved intestinal obstruction, somehow you have decided that you want to start with a conservative approach. So don't wait the sun to rise again during admission and set again. Because if you do not take a decision in that time period, there will be more chances of complications, right? So thank you very much.